Thank you for joining us today. Good morning. First, I want to thank the AST for allowing us to have this Science Innovation Theater. It's a privilege to be here. Our session today is going to be talking about innovative approaches to CMV management in solid organ transplant, transforming the role of cytogam. This is a promotional talk, and this is our disclosures for Kamada. My name is Winston Alley. I'm the Director for Medical Affairs at Kamada. It's my privilege and honor to introduce Dr. Mary Budev as our speaker today. She's going to be discussing the current state of CMV in solid organ transplant, the ongoing challenges that CMV continues to pose, our evolving understanding of CMV risk profiles, and the need for innovative approaches. Following her talk, I'll be discussing how Kamada is supporting and addressing this need with our hyperimmune globulin therapies and our clinical program that's aiming to innovate and transform cytogam's role in CMV management. Dr. Budev is the Medical Director for Lung Transplant at Cleveland Clinic. And so with that, I'd love to introduce her.
All right, if going back to 1979, there was a seminal article that was published in JAMA by Dr. Henry Belfour, who actually described CMV as the persistent troll in transplant. He used the term troll because of the unpredictability of CMV and its impact on overall health in transplant recipients. Even today, if you go from 1979 to the present day, even despite our recent advances in antiviral therapies, CMV continues to remain one of the most common complications after solid organ transplant. And in fact, if you look at patients that have CMV complications or CMV infection, they actually have an overall health quality of life that is actually reduced. If you look at healthcare utilization, CMV after a solid organ transplant increases healthcare utilization and also leads to overall use of resources and the transplantation costs. Now, I just want to go over a few points in terms of how often CMV infection and disease rates actually happen, not just after solid organ transplant, but after prophylaxis is stopped. And the graph that you see here actually illustrates several clinical trials and the incidence of CMV disease as well as CMV infection after prophylaxis is stopped. We won't go over every single one of these trials, but I'd like to go through a few of them. The first trial I wanted to go over was by Bloemendaal. This comes out of the Netherlands, and they looked at kidney transplants, the high-risk kidney transplant, the donor-positive recipient negative kidney transplants. And they found in this study, this was in over 2,000 kidney transplant patients that were followed for about 9 years. And what they found was there was about a 40% CMV infection rate after prophylaxis was stopped. Nina Singh looked at a liver transplant cohort of donor-positive recipient negative patients, and they found almost a 19% CMV disease rate after prophylaxis was stopped. If you're talking about thoracic organ transplantation, the incidence of CMV can actually vary quite a bit. It can be because you're looking at these retrospective cohort studies, and the incidence can be anywhere from 11% up to 40%. But I think the main takeaway point for you is that our modern CMV management strategies do not mitigate the risk of CMV after completion or cessation of prophylaxis. And that's a key point to understand. Another take-home point is the fact that CMV is a risk factor for post-transplant mortality. And I'm going to share with you 3 studies that actually support this. The first study is the study into the far left of the screen, which was actually published out of a group from British Columbia. This was recently published in 2024, and what they found was that CMV viremia was associated with the decreased probability of patient survival at 12 years. This paper is a very interesting paper, and if you get a chance to read it, I really highly suggest that you do, because it also looked at CMV pharmacokinetics, or I should say overall kinetics. And what they found is CMV severity, CMV disease duration, as well as peak CMV levels, actually predicted graft survival and were clinical predictors of overall patient survival. And they found if patients had late onset CMV, which is defined as greater than 3 months from the time of transplant, there was an association of overall decreased survival at 2 years. And this is depicted by the dotted line, or actually in this graphic it looks a little bit different, but this is a dotted line. That's the lower line depicting worse survival compared to patients who had no CMV in the dashed line that's shown above. The last study I want to share with you is a study that came out of the UK. This was by Desai et al., and they looked at CMV serostatus and its actual impact on overall survival. And in this retrospective study, in a group of solid organ transplant patients, over 22,000 transplant patients, they noted that there was a decreased patient survival in CMV positive, recipient negative patients compared to those CMV negative and negative patients. It's important with SRTR data to know what the incidence is of this high-risk cohort of donor positive and recipient negative. And from the SRTR data from 2005 to 2019, the incidence of D positive, R negative incidence in kidney transplant recipients is about 18%. For lung transplant, heart transplant, and liver transplant recipients, that incidence of D positive, R negative, the highest risk group, is about 28%. Now let's switch gears and talk about the clinical manifestations of CMV in solid organ transplant. These manifestations could be direct effects. It could also be indirect effects of CMV. Let's first talk about the direct effects because these are ones that are really, really interesting. These direct effects are usually due to CMV virus replication, dissemination of the virus, and tissue invasion of the virus. CMV infection is when you have detectable virus, but you may not have any symptoms. CMV disease is very different. This is when you have detectable virus and you have clinical signs and symptoms. And these clinical signs and symptoms can fall within a spectrum. It could be a simple viral syndrome that patients are experiencing, or it could be something much more sinister like end organ damage due to tissue invasion by CMV virus. Let's switch gears and talk about the indirect effects of CMV. And this is due to the effects of CMV-mediated immunomodulation, a field that we're just getting to know more about. This is the immunosuppressive and the inflammatory milieu that occurs due to this CMV-mediated immunomodulation. And this could be the development of secondary opportunistic infections. These include bacterial infections or even fungal infections. It could include the development of malignancy like PTLD that's associated with EBV. It can lead to acute graft dysfunction or graft failure or rejection, or even late-term graft failure or graft rejection like chronic lung allograft dysfunction, and this could ultimately lead to malignancy. So these clinical manifestations of CMV are something to keep in mind and to take very seriously. I think all of you in this room understand what the traditional risk factors for CMV that are listed on the right-hand side of the screen, but I think there's an area of evolving understanding of different patient risks. And in fact, some of these patient risks are a little bit nuanced. For example, the use of a belatacept-based immunosuppressive regimen could actually be a risk factor for CMV. One area is the short telomere syndrome. And for those of you that are not familiar with this, I'd like to talk a little bit about this. So as some of you may know, telomeres are the caps on your chromosomes. We all have these, and we all have shortening of our telomeres as we naturally age. But in certain patients, they will have abnormal shortening of telomeres, and that is called short telomere syndrome, especially when the telomere length is extremely short for that age, less than the 10th percentile or less than the 1st percentile. These are patients that are extremely vulnerable to certain things. And in fact, if you have extremely short telomeres, you could be predisposed to pulmonary fibrosis, hepatic cirrhosis, bone marrow suppression, wound healing, renal failure, and also T-cell dysfunction. So this is very important to keep in mind because these patients are vulnerable to several different types of viruses and herpetic viruses. There's been studies coming out of John McDyer's lab and Mary Armanos' lab in Johns Hopkins, which have showed in the high-risk CMV group, the recipient positive, donor negative group, that have the shortest telomere lengths, the ones less than 10 percentile or close to the first percentile, that these patients, when their CMV prophylaxis is stopped, they are very likely to actually have CMV breakthrough and evidence of reoccurrence of CMV and further impact on their overall grafts and other infections. So therefore, in lung transplant programs at the present day, if we have a patient that has short telomeres, we test our patients at the Cleveland Clinic. Not all organ transplant centers do that, or lung transplant centers actually do that. But we preemptively, if you have IPF, we do test you for short telomeres. Why? Because we want to know if we need to keep our CMV prophylaxis going for lifelong. And also we do it, and I'm going to talk a little bit about this, in ways to mitigate CMV infection or CMV disease in certain populations. So I'll come back to this in a moment. Another population and group that is growing is our geriatric patients. Immunosenescence or overall senescence of the immune system can lead to T-cell dysfunction, and this is another group that is very vulnerable to CMV. So the management strategies for CMV, we know that the two ways to prevent CMV are either prophylaxis or preemptive therapy. So as I close out, I'm going to go over a few other things. There are many challenges with CMV and solid organ transplant. I'm not going to be able to talk about all of these, but I do want to highlight them. One of these challenges is that we have limitations in our current therapies and the strategies that we use. We know we're having emergence of resistant and refractory disease with CMV. We talked a little bit about the post-prophylaxis late onset CMV. We still don't know how to address this appropriately, and we need to look into different strategies. The patient risk profile is not just about being a mismatch, but there are several nuances, like with a short telomere patient, that may make a patient more vulnerable to CMV. We'll talk a little bit more about that in a few moments. How do we use newer diagnostic tests that I've listed here, and what role do they play in our assessment of CMV infection and CMV disease? We really don't have a whole lot of novel therapies, and our understanding of that immunomodulatory component of CMV is quite limited. In terms of vaccines, we have no vaccines for CMV right now for solid organ transplant patients. All the vaccine trials that have been going on for about 50 years, or talked about for the last 50 years, are in all non-solid organ transplant patients, and it'll be some time until we have results from those sort of trials that we can take this to our solid organ transplant population, but it is something that it will be in the future hopefully available. Although we've seen all these challenges, we as a community need to rise to this challenge, and we need to have a personalized approach to CMV management in solid organ transplant. I did talk a little bit about the telomere and the short telomere patients. One thing that we do at our own institution, besides testing all patients that have IPF or liver cirrhosis that need a liver-lung transplant, is that we, at the time of transplant, if we know that they have short telomeres and they're CMV negative, we try to match them with a CMV donor if their clinical situation will allow for this. In addition, when we know a patient has CMV negative status and they also have short telomeres, these are patients we know that can have bone marrow suppression as a result of their CMV, as a result of their short telomere syndrome. And in these patients, frequently what we'll do is we will never place them on Valsat or valganciclovir because of the risk for bone marrow suppression, neutropenia, thrombocytopenia. We actually place them on acyclovir and letermovir and work with their insurance to hope that they can get this before they even get the transplant. So we go through that process. And these patients, again, will be left on these therapies lifelong. It's really important now as we rise to the challenge, not only do we personalize our approach to CMV in these special populations or populations that have a higher risk, that we also explore combination therapy using different antiviral therapies. What is the role of, for example, CMV, IgG? And Winston will talk a little bit about that. And what does combination therapy add to the table? We also need to use these novel diagnostic tests to help achieve a personalized approach and not treating every single patient the same. So our toolbox contains several of these antiviral therapies, CMV, IgG, immunosuppression, optimization, and trying to stop some immunosuppression or lowering immunosuppression. And it also includes special diagnostic testing. So we need to rise to the challenge and not be discouraged by CMV infection, although it's really common after transplantation. I'm going to stop here and I'm going to turn the microphone over to Winston. I want to thank you for your attention.